Good evening, everyone, and welcome from Scottsdale, Arizona to the Orthodontic Acceleration to Advanced Cases. This is part one of a two-part series. The first presentation tonight is based on solely focused on manual osteo-perforation, which is now the new nomenclature from micro osteo-perforations. For those of you who are unfamiliar with me, I've been speaking on behalf of Invisalign since 2004. I'm currently the dedicated Invisalign instructor and adjunct professor at the Orthodontic Graduate Program at AT Still here in Mesa, Arizona. And I serve on the Clinical Advisory Board for Propel Orthodontics. Anybody that's been in practice for more than 10 years can probably agree with me that they've noticed that patients are just simply getting more impatient. And my own personal experience, I think millennials are the worst. They're constantly distracted. They're always time constrained, and they oftentimes are just simply puffed up with self-perceived self-importance. It's not unusual for patients to get in the chair when they've had a scheduled for 20 or 30-minute appointment, and they tell me they've got to be out of there in 5 minutes. So it's true. Patients simply are getting very impatient. And baby boomers have shown an increasing interest in orthodontic treatment the past 10 years. If it's less obtrusive, it's socially acceptable, and most importantly, if they can get in and get out, they want it fast. And research certainly indicates and supports that millennials and baby boomers alike are now mimicking teens in their diminishing capacity for both patience and compliance with orthodontic treatment. Everyone's getting impatient. And more than ever before, orthodontists today are now faced with new and challenging treatment time constraints, such that some of these impatient patients can easily become your ex-patients. So in response to this, we have accelerated orthodontics. And currently, there's three modalities of treatment from the acceleration field. One is the manual osteoperforations, known as MOPs. The other is pulse vibration technology. We have 2 vibrators, to my knowledge, on the field. And then low-level laser. I'm going to direct all of my attention tonight to manual osteoperforations. Accelerated orthodontics has created a paradigm shift in the manner in which orthodontic patients are being currently treated. And in my personal experience and my viewpoint, the combination of Invisalign and MOPs has the potential to change the face of orthodontics as it's currently practiced. Now, when I first saw this, I think this is probably the best overview of explaining just how MOPs and pulse vibration and low-level lasers has an impact on the physiology and the biochemistry of bone physiology. But just to break this down, you can ignore this, the left half of this chart just for our practical purposes. The most important thing to focus on is orthodontic forces in conjunction with tissue damage results in a flood of pro-inflammatory cytokines. And this is particularly important for MOPs because with manual osteoperforations, you're getting overt tissue damage. Although there's quite a number of pro-inflammatory cytokines, which I'll go over very shortly, the most important information that we have right now, basically which is elucidated back in the late 90s, is that with MOPs, you get MCSF, and you get rankle, and you get OPG. With regard to pulse vibration and low-level laser technology, it appears that it stimulates the rankle submission and the OPG, but it doesn't seem to have a huge impact with the MCF unless you go all the way around the bend here and come back to it. So this is the most important cytokine, or it appears to be, with regard to MOPs. And just a quick review of bone cells. Obviously, osteogenic cells develop into osteoblasts. Osteoblasts are principally responsible for forming the bone matrix, and it's the osteocyte that's the most ubiquitous bone cell currently. Osteocytes are terminally differentiated cells of the osteoblast lineage that embed in mineralized matrix, and it seems that research suggests that these are the cells that send signals that regulate bone modeling and remodeling. So osteocytes obviously are the most abundant cells in bone, and so it makes sense that they're the regulators of bone physiology. Although every time I see this, this reminds me more and more of the breakfast special at IHOP. It's important to understand that osteoclastogenesis requires inflammation in the area, and damaged osteocytes activate osteoclast precursors. Mechanically damaged osteocytes secrete a number of pro-inflammatory cytokines that include MCSF and rankle. It's not alone, though. Obviously, there's a huge cascade of a number of cytokines that regulate osteoclast formation, and these are only several of them. I emphasize these last three simply because there seems to be more information with regard to how they have a direct impact on bone remodeling. It's also important to remember that the rate of bone resorption can be regulated by not only changing the number of osteoclasts in the area or the site, but also changing the activity of the osteoclasts. This is particularly important when it comes to MOPs. MCSF is a particularly important cytokine simply because it has been found to rapidly and potently augment the rankle-induced resorption activation of osteoclasts. It also dramatically stimulates osteoclast motility and spreading. And finally, it's been found to enhance osteoclastic survival, migration, and chemotaxis. So in a nutshell, what MOPs does is it stimulates MCSF, and MCSF apparently has the capacity to literally caffeinate these osteoclasts. MCSF is a particularly important cytokine because mechanically induced tissue damage stimulates MCSF-dependent bone marrow macrophages to differentiate into osteoclasts through a mechanism that's solely independent of the rankle-rank interaction. So this is exceptionally important with regard to MOPs. Pulse vibration, on the other hand, appears to create tension within osteocytes. There's no overt damage to osteocytes, just tension. And that tension appears to stimulate the activation of rankle, which is another cytokine. So what's the difference between these two modalities, MOPs and pulse vibration technology? Well, it appears that with MOPs, at least for the most recent information, that MCSF plays an integral role in stimulating osteoclast activity, which explains why you can really, it seems to actually accelerate tooth movement. Pulse vibration, on the other hand, does include MCSF, but it doesn't appear to play an integral role in stimulating osteoclast activity. So that's the most important difference between these two modalities. Now, a lot of doctors will ask, well, what prevents this cascade of cytokines from getting out of control and starting to do tissue damage in other sites where we don't want that to occur? And the answer is OPG. OPG is a cytokine that prevents excessive bone resorption and limits it to regionally by inhibiting osteoclastogenesis. So this cytokine is the gatekeeper. It prevents things from getting out of control, and it is a limiting factor to confine and contain the extent of what MOPs can do. So specifically, OPG inhibits the differentiation of macrophages into osteoclasts, and it prevents excessive bone resorption by binding to rankle or competing with it and preventing it from binding it to its rank receptor. So the reality is that rankle is simply a protein that sits on the surface of osteoblasts, and under the right circumstances, this cascade effect, it releases the rankle and it starts to seek its rank receptor on pre-fusion osteoclasts. Once these two hook up, then this allows these pre-fusion osteoclasts to come together to form multinucleated osteoclasts, which is the activity that actually activates these osteoclasts. And you can see at the same time, OPG is out there trying to compete with rankle by hooking up with rankle to prevent it from hooking up with its receptor site on the rank to start the osteoclastic activity. So this is the activity that occurs that helps create this balance and blocks the interaction between osteoblasts and osteoclastic precursors. So this is the way I started. I started with the very first introductory accelerator driver, and it was perfect because it had this little light that lets you know when you're in deep enough, and it was pretty simple to use. However, if you started doing complete mouth MOPs, it started to getting a little tough on the wrist, especially if you were doing more than one patient per day. But when I first started with MOPs, I followed the administration protocol to the letter. I followed these steps, used the chlorhexidine rinse, and when it came time to anesthetize, I used the topical anesthetic which is proprietary coming from specific pharmacies. And I use the BTT, and if there were certain situations where the BTT needed a little augmentation, then I use the local antiseptic Septicane. And I followed the directions and went in at 3 to 5 millimeter depths from molar to molar. And this is how I started. Just like with most everything else, it's usually patient-driven. And this patient came in, and she had already set previous consultations, and understandably, previous orthodontists wanted to take out that lower incisor, which makes sense, and it would have really truncated her treatment dramatically. But she came and said, I don't care what it takes, just I don't want this tooth extracted. And so I said, all right, then we can move forward from that premise. And the only problem was that I couldn't create space with arch development because the arch development was restricted by the presence of a bridge. So that meant all the space had to be created through interproximal reduction. So we're getting 7 months in the case. We've gone through 14 of the 42 aligners. And all of a sudden the patient comes in one day and says, you know, this is taking too long. And she wants to know what can be done to speed up. And so I'm thinking, geez, what happened to, I don't care what it takes. So this time I had already been introduced to MOPs, and I thought this was likely the best solution out of this predicament. So I reviewed the MOPs procedure to her, and she said, let's do it. So we did. So the patient underwent MOPs and was instructed from that point forward to exchange the next 28 liners weekly instead of every 2 weeks, to the normal Invisalign protocol. And for the last 28 aligners, she was on a 7-day aligner exchange protocol. And so the total treatment time of 42 aligners turned out to be 14 months of total treatment, and we were able to achieve a reasonable result. So as I moved on and continued to experiment with MOPs, found that it was especially useful in particularly difficult individual tooth movements. And so that's what I focused on, unless patients were really in a hurry to change their arch form. And so it helped me out of some challenging situations. This gentleman, although he was a pretty easy demeanor, he was also impatient, just like so many of my patients are. And after about 16 months of treatment, going through the aligners, with him wearing them usually 14 to 16 hours a day instead of the 20 that is recommended by Invisalign, we were able to get through most of our treatment objectives except for a couple of lateral incisors, especially this one. And he said that that was the only reason why he did treatment, so he was a little anxious and he didn't really want to go through many more aligners. So I thought that, well, if I'm going to put him through refinement, I really have to throw the book at him. So the course was to do 10 additional aligners. I told him that we're going to have to do Propel, and I was going to use some auxiliaries on the palatal surface of the teeth, so we can really focus on getting that rotation and making the patient happy. And so that's what we did. And so I didn't want to take any chances, so I literally, did 3 perforations on each side. Although now I know that's probably really needed only 2 perforations on each side. But I went all the way up that route there because I want to make sure that thing turned around as fast as it possibly could. And it did. And you can see the auxiliaries that I used. I had him wear the aligners in conjunction with this. And he was able to finish treatment on a total of 32 aligners, 18 months and 2 weeks. So we only added a couple more months of treatment in order to meet our objective and get out of the case. So I've started using MOPs with palatal impacted canines, and what's great about that is I can go to the oral surgeon's office, and since the patient's completely under, that obviated the need for me to do any additional anesthesia. So it gives me an opportunity to place all my perforations without having to do any palatal injections. And so although it's difficult to determine whether MOPs is actually accelerating the tooth movement, it appears, at least my clinical impression, is that it's really helping to move these canines into place. And there's nothing better with MOPs in terms of extruding maxillary incisors. Ever since I started attempting to put smile arcs into all of my Invisalign cases, it makes it more challenging because by using the nicosesis extrusion protocol for these anterior maxillary anterior incisors and getting them to extrude, it really adds an inordinate number of aligners. So it used to put me into quite a predicament until MOPs came along. And with MOPs, now I'm not concerned about the number of aligners that it adds to the protocol, because now we're flipping them out every 7 days. And so even with 41 aligners, he was able to finish in 10 months and 1 week of treatment and get a very reasonable result. And so I started extending my protocol, especially with a lot of these bimaxillary constriction cases, and especially if I had a particularly difficult tooth to move, for example, this extreme lingual version of this lower right 5. But what I really want to do is I want to get a more broadened, more nathologically sound arch form out of this patient. So she agreed to undergo MOPs from molar to molar in both arches. And once again, on that 7-day aligner exchange protocol, even with 50 aligners, we were able to complete treatment with a very reasonable result, meeting most of our treatment objectives in a very reasonable treatment time of 12 months and 3 weeks of treatment. And this actually changed everything for me with regard to my MOPs protocol. Once the reusable driver came out with its 2 disposable tips and its textured handle, this handle really made things so much easier for me. And so now it was no longer a problem because of the simplicity of its use to do more than 1 patient a day without going home with a sore wrist. So this changed everything and really increased my enthusiasm for recommending MOPs to my patients. The other circumstance that really turned my head and really helped me embrace MOPs was an article by Dr. Thomas Shipley on increasing the rate of aligner progression. And I had the opportunity to visit Dr. Shipley at his office. And in the course of conversation and watching him work, it was Dr. Shipley that, to my knowledge, was the first one that insisted that the science really justifies the aligner exchange of every 3 days rather than 7 days. So I went back to my practice and I immediately started changing my protocol. And just like with everything else, it's usually the patient that drives or motivates you to press forward, because sometimes you feel you have no choice. In this particular patient, she was a cocktail attendant, and she, according to her, she was not allowed to even wear any Invisalign at work. And she happened to have 6 weeks off, and although this is a very minor situation, this aligner, this malalignment of her lower incisors had always bothered her, and she wanted to get that cleared up. And she was wondering if Invisalign could do that within a 6 weeks period of time. I thought, well, I can do some Invisalign Express, but I'm going to have to do MOPs. And so I reviewed the protocol with her. She seemed to embrace it, and that's exactly what we did. And now, I had found that I wasn't able to experience the same type of success that Dr. Shipley had with exchanging it every 3 days, probably because my patients just aren't as adherent with their protocols. In other words, they don't wear the aligners every 20 hours the way they're supposed to, 20 hours per day. Mostly they'll admit that they wear them 14 to 16 hours a day. But with MOPs, it's not too much of a concern. However, that's when I started putting everybody on a 3-5-day aligner protocol, where I've actually placed the responsibility for moderating their treatment back to the patient's laps. And I tell them that after 3 days, check the tracking. This is predicated on the fact that we've trained them to understand what good tracking is. I also tell them to do a preemptive strike on the lateral incisors, because those are the first ones, in my experience, that are most unlikely to untrack. So with using the Nicosia extrusion protocol, telling them to focus on this, and if they found that everything tracked except the lateral incisor, use the chewies and give it another day or 2, and once it tracks, then to flip out the aligners. And the patients seem to understand that. And so with this 3-4-5 aligner exchange protocol, I've been really enjoying a significant degree of success. And so, and it just seems to keep on coming. So then I'm getting these patients that come in, some of them from other Propel patients. And this individual is a professional golfer from Scotland. And although this malocclusion never bothered him, according to him, he said all the Scottish individuals have class 2 malocclusions. But it just so happened Mr. is Miss Scotland, and she was getting married in Spain to a prominent professional soccer player. and his family encouraged him to fix his teeth before the wedding because he was going to be an integral part of the wedding. So instead of getting crowns, he didn't want his teeth cut down, so he came and asked if it was possible to get these teeth aligned within 6 months. And I told him the only way we were going to be able to do that and meet some of our treatment objectives is to go through MOPs. And after explaining the procedure, he seemed up for it, and so that's exactly what we did. And this is the situation that I find myself in. With 36 aligners, with the old aligner protocol, that would have been 18 months. And you can see the reason why. I'm using the Nicosia extrusion protocol. I've got some lateral incisors that I have to rotate, trying to get a reasonable smile arc and get some degree of intrusion of the lower incisors to prove the overbite just a little bit. That's a lot of aligners, but on a 3, 4, 5-day aligner exchange protocol, things worked out rather well, and he was able to finish treatment with a very reasonable result in 3 months and 3 weeks, even in time to whiten his teeth before the wedding. And so this is what I've been experiencing now. This patient, he's a chiropractor, fully aware that his malocclusion with the steep interincisal angle is causing occlusal traumatism and contributing a lot to this gingival recession, but he had no interest in braces. He was actually preferred to watch his teeth, get continually traumatized. He already had some significant incisor attrition on the mandibular incisors. But with Invisalign, he was interested, but he didn't want to take much time. So I said the only way to do this, to meet these objectives, to get these teeth out of harm's way, is to go through Invisalign and manual osseous perforations. And he was on board, and that's exactly what we did. And on the 3, 5, 7-day exchange protocol, we were able to finish in 20 aligners in 3 months and 1 week of treatment and get the teeth out of traumatic occlusion. And so this is basically how I've reoriented my Invisalign practice. I've learned to really look for these cases and to suggest MOPs, and quite honestly, with what I've been experiencing, I've done over 100 MOPs cases now. I honestly feel that I'm able to get better smile arcs with better tracking, more consistent results by adding MOPs to my protocol with my Invisalign protocol. That's exactly what we did with this gentleman. 27 aligners. In the olden days, this was over a year of treatment, but now with the 3, 5, 7-day exchange that MOPs permits, I'm able to get a very reasonable results, decent smile arcs in 3 months and 3 weeks treatment. And once again, this patient was brought in by another MOPs patient. She was getting married in Paris, and she wanted to be finished in 9 months to meet her date. And she said, I don't want to be having wedding pictures with this crooked smile. And so that was the focus. The treatment objectives were to give her a little better arch form, clean up this crowding, and give her a smile that she could be happy with. So the only way to do that and to meet those objectives in the time constraints were to go through Invisalign treatment with MOPs. And that's exactly what we did. And with 34 aligners in the old aligner exchange protocol, that would have been 17 months. But with the 3, 5, 7-day exchange protocol, it was 7 months and 2 weeks treatment, able to get rid of that cant, give her a reasonable smile for her photographs, clean up the lower incisor crowding, and also give her something, give her a slightly different arch form. Obviously, it was mitigated by the fact that she had a bridge, and so that really prevents you from really getting the type of arch form that you want. But it was reasonable, and I thought we got a reasonable result. And so, because I'm the dedicated Invisalign instructor at the dental school, I tend to get a lot of dental students, especially in their final trimester before they graduate, and they start looking and realizing that they really don't want to go out into the world as a dental professional unless they've cleaned up their incisors. And what this individual said is that she obviously had orthodontic treatment before, and she was wearing a Hawley retainer religiously, but her concern was when she didn't wear the Hawley retainer, the diastema would open about 3 times what occurred at this particular photograph. So she wanted to do something definitive. And I told her that the real problem was downstairs here, because it wasn't only the crowding, but because the incisors were proclined, they were actually causing traumatic occlusion and causing these teeth to procline in the maxillary incisor and creating the diastema. So we've got, in my mind, this is a lot of work. Previously, in the olden days, I would have regarded this as a possible Invisalign Express. But since my objective now is to get reasonable smile arcs and get rid of these reverse smile arcs, that adds an inadvertent amount of aligners. But with a number of aligners no longer a concern, as long as I do MOPs, I can actually move forward with all the treatment objectives. So I wanted to clean up the aligners, clean up the incisors, upright these incisors, get a little bit better arch form, more pathologically sound, and get these roots parallel and close that diastema. And so with 24 aligners, once again, in the olden days, that would have been 12 aligners with all this tooth movement, nicosis extrusion protocol, using 45-degree gable bends to get root parallelization. That's a lot of aligners. But with Invisalign and MOPs, we were able to complete treatment in time for graduation in 5 months on a 3, 5, 7-day exchange protocol, getting a reasonable smile arc, getting a little bit better arch form, and getting those lower incisors upright. And so this has helped me push the envelope. Actually, patient demand has helped me, go beyond my range of being comfortable. So this patient came in. She was a very pleasant patient, and what originally happened is she wanted Invisalign, and so I went to the Invisalign protocol, and when I told her how long it was going to take, she broke down and cried. And I said, what did I say? And she said, well, I was just hoping that I'd be finished in time for my daughter's wedding. I said, when's your daughter getting married? She said, 9 months. And I went, perfect. I told her, and I explained the MOPS situation to her, because I'm still being reactive rather than proactive in a lot of these more difficult cases. And after I explained the protocol and told her that I was confident that with MOPs that we could finish in that deadline, she said, go ahead and stick me. And that's exactly what we did. And for, once again, 34 aligners in order to meet all our treatment objectives. Back in the day, that would have been 17 aligners, 17 months. But with Invisalign and MOPs, we're able to get through all of this, get a much better arch form, rotate those lateral incisors, get a smile arc using the nicosis extrusion protocol, and to line up the lower incisors. And we were able to not only complete treatment in 6 months with a very reasonable arch form, decent smile arc, but we had plenty of time for her to get her teeth whitened in time for the wedding pictures. So in my own personal experience, in my own practice, I think MOPs has demonstrated the capacity to resolve exasperating clinical challenges. Those things where things just aren't going well and you just really want to get out of the case, but you don't want to compromise any of your treatment results. And this is a classic example. Now that I've been using Invisalign for, since 1999, and I've treated over 1,600 cases, I tend to push the envelope and be a little bit more particular about what I'm doing with Invisalign. Now in this particular case, I'm trying to get some incisal guidance without interrupting her gingival display and the amount of incisor display. So that means for the first round, I've got to intrude the posterior teeth so that I can get some more overlap without, changing the vertical position of her maxillary incisors. So we put her through 32 aligners and with the old protocol, and that would be 16 months of treatment. And then we went ahead and put her through another 20 refinement aligners so that we could get a reasonable smile arc. So that added additional 10 months of treatment. So here we are in 26 months of treatment, and I'm not happy with the smile arc, and neither is she. She doesn't like this at all. And more importantly, I don't have the incisal guidance that I'd hoped to. It's got the arch form, but I'm far from pleased with this case. So at this point, I just sat down and said, the only way we're going to get this done without adding a lot of treatment time, because she was getting burned out by this time, is MOPs. And I explained to her I thought that we could finish this in just a few more months if she underwent manual osteo-perforation. And she said, let's do it. Let's finish this. And we did. But it was 30 aligners. And once again, 30 aligners in the old days would have been 15 months of additional treatment, which would have been totally unacceptable to her. But you can see I've got her dressed up like a Christmas tree because I don't want to take any chances. I've got all the attachments to ensure that I can get these roots lined up and get a good smile arc and get some incisal guidance. On a 3, 5, 7-day protocol, She was exceptional at doing that, and we were able to finish in 3 months, 2 weeks, meet all of our objectives, get a good incisal guidance, get a reasonable smile arc, get all the arch form that I'd hoped to get out of her. And out of all this, total treatment, we were able to finish in reasonable time with regard to MOPs. And there's nothing, for a while there, I thought, well, I've got patients outside of the country. And this is a school teacher that was actually just on a sabbatical to improve her Spanish. And so we got her dressed up with the aligners, and then she left the country for about 6 months. So I thought, well, that'll be okay. So, and she was an exceptional aligner wearer. But unfortunately, when she came back looking like this. And I said, didn't you notice that this tooth here was getting way out of control? And she said, yeah, but everything else looked good, so I thought I'd just keep going because I didn't want to miss any treatment time or extend treatment beyond what it should be. And so I thought, all right. So I explained to her that I think the best thing to do to get out of this would be braces, and she was adamantly opposed to that. She said, came for Invisalign, I want to finish for Invisalign. So I told her I thought that the only reasonable way out of this predicament was to do refinement with MOPs, and I was going to really focus on doing osteo-perforations all the way up the root on both sides of this tooth. And so that's exactly what the game plan was. Now, 52 aligners. In the olden days, you can just imagine how many months that would have been, and that would have been totally unacceptable with this patient. And the bottom line is, you can see I'm not doing too much of tooth movement in the maxillary except for that one lateral incisor, and that's what's causing all this. I purposely slowed down the velocity of tooth movement to 0.15 millimeters per aligner, but that's what adds all the aligners. But with MOPs, I felt confident that we could do this in under 6 months, and that's exactly what we did. We were able to finish this case with a refinement of 5 months and 2 weeks treatment time, and get a very reasonable result with decent arch form. So I got myself out of what I thought was going to be a very difficult situation. And then this gentleman, obviously he's got a whole host of problems, not more importantly that seems to be suffering from GERD just based on all the dishing out of his teeth and including the nutritional wear that's been going on because of his class 3 profile. He's got some severe abfractions. He needs full mouth rehabilitation. And what finally motivated this individual to come into the office is, once again, his daughter was getting married. The only problem is, he said his daughter was getting married within 9 months, and he really needed to do something quickly. And so he also informed me that as a businessman, he wasn't in a position to be wearing any elastics. So I knew this was going to be a challenging case. To me, this would be impossible to do without MOPs. But I told him that the only way that we were going to meet the deadline so that he could get some restorative dentistry on his maxillary teeth and to be able to give his daughter away was to go through Invisalign and MOPs, and he agreed. And once again, the first round of treatment, the goal is to open the bite since he had truncated it, his maxillary incisors, so I give the restorative dentist some room so they put some crowns on. But you can see I have really done extensive IPR in his teeth because I figured he's going to get crowns anyhow, but I've got to get these teeth out of harm's way. In addition, what I like about Invisalign and the Bolton analysis, it allows me to do some planning and some spacing so we can get some reasonable results for the planning for restorative dentistry. So all I'm trying to do is procline these within a reasonable framework and do some reasonable spacing so that we can get some teeth that are and restorations that look reasonable with regard to arch symmetry. So hopefully we're going to get this. You can see all this IPR had to be done at the beginning of treatment, so I saw him 2 weeks in a row because I couldn't do all that IPR at one time. We had to get this case going. And so after 3 months and 1 week of treatment, we've got him into the ballpark, but we're certainly not there quite yet. And so we're pushing the envelope here, so we've got to put him through refinement again. And we've got another 21 aligners, and we've got a heck of an awful lot more IPR because we can't use class 3 elastics. So I've got some lingual root torque going on here with the power ridges, got a lot of IPR, and we hope that this will do it. And you can see I've still got to get these incisors back and round them out and get them out of harm's way so the restorative dentist can do their job. So we were able to finish in 5 months and 2 weeks of total treatment time on a 357-day aligner exchange. Total treatment was 47 aligners, and he was able, right from my operatory, he walked over to the dental office and he immediately started his restorative dentistry, and he was able to go to his daughter's wedding. He decided to hold off on the lower because he said that people couldn't see his lowers, but he had a very nice response at the wedding, and apparently he's going to return to finish off his restorative dentistry. But I don't see how I could have possibly even considered this case without a combination of MOPs and Invisalign. So naturally, it's encouraged me to stick my neck out a little bit and try some other things. But once again, anytime I push the envelope, it's always because it's patient-driven. And by coincidence, I happened to have been in the office on Christmas Eve, and I was just cleaning out some desk drawers. I was the only one in the office, and then I heard a banging on the window. I went to the front desk and looked out the door, and there was this individual, and he was just literally a wreck. And so I opened the door, and he said, "Is there any way that you can help me?" He said, "I've got an important corporate Christmas party to attend, and I just snapped off this tooth." He said, "And I just can't go to the party like this." So I had to call in one of my auxiliaries, take an impression for an Essex retainer. I told him to go out for a Starbucks, and she built a tooth out of plaster, and then she made an Essex retainer. Then we filled it in with white filling material, and he came back an hour and 15 minutes later, and he went off into the Christmas party with the Essex retainer with a tooth in it. And I told him, and of course, then when he came back, took an x-ray, and we had to get rid of this fractured root for the lateral incisor. And I said, we've got to do something about everything else here, so we're going to have to do some orthodontic treatment. So the treatment plan involves doing maxillary Invisalign, because Invisalign's great for filling in that slot, and I told him that he could actually eat with the upper aligner in so that people wouldn't know that he was missing a tooth. And then it also involved lower fixed appliances, so I get a reverse curve in there and start working on this overbite. And then we built twin towers to give him some stops so that we can open the bite so he wouldn't shear off the lower brackets while we're busy intruding those. And then also the treatment plan involved MOPs to the entire maxillary arch, so I could procline these incisors and get them out of harm's way as quickly as possible. And so as you can see, we mopped all the way around the street there. And now by this time, I was only doing approximately 2 perforations, which is now our standard protocol. Unless we have an exceptionally long canine, then we're doing 3 perforations on each side of the canine. But this seems to work out fairly well. After 40 aligners out of the 53 total aligners, 4 months into treatment, with him exchanging aligners every 3 days, obviously I know I've got a 100% compliant patient because he's not going to be walking around without that tooth. We were able to start reducing these bite turbos as we got the upper incisors proclined so they wouldn't be engaging the brackets on the lower incisors. And then so we started removing the bite turbos. And then we had a little bit of a snafu. Some of the aligners showed that were not manufactured ideally, so that we weren't able to get, in other words, the aligner was way down here, and so it bothered him because you could see this dark space there. So we had to reboot him, get this, with the same protocol and the same sequence. We just asked him to bring this up so that we could fill it in so he could be comfortable walking around and not showing any dark circles and once again, not letting anybody know. So it sort of slowed us down a bit, but not too badly, and we're still able to continue. At this point, he's exchanging aligners on a 5, 6, 7-day protocol, and we were able to significantly reduce these bite turbos as the maxillary incisors were proclined and gotten out of harm's way. And so now we're 14 months into treatment without maxillary Invisalign in place and the bite turbos, and so you get an idea of where we are. And here are 15 months, and we've just about gotten rid of all of the bite turbos. And now I did a pano repo to try to get a little bit better leveling of the lower arch. Then right after that, we'll deband him. I'm going to reboot him. We'll distalize these, and then we'll start planning for balancing out the spaces and his restorative dentistry so that this space will equal the contralateral width of the lateral incisor. I think we're planning on actually creating some space here so he can have lateral incisors that are approximately 80% the width of the adjacent central incisors, give a little more balance. You can see I'm not going to have too much problem taking care of this, and I'll just have to distalize this, and that'll give me some space to correct his midline. And in addition, get him a reasonable result. At this point, without my bringing it up, he even asked me, don't you think I should get rid of this implant and redo it? And that's what I want to hear from patients. So he's willing to go the full 9 yards. So we're in the process of removing this while I'm still working on the, then he'll get another implant after that bone fills in when it's time. So he'll actually have 2 implants. So now I've got a totally different protocol. Just because of MOPs with regard to my aligners. So now at the first appointment, whereas we used to just give out the aligners and see them a week later and start putting on the attachments, now at the first appointment, so that we don't overwhelm the patient on their first appointment, we try to put the attachments on at least one arch, and I start the IPR. And then we schedule them a week later or 10 days later for our second appointment, and at that appointment we're going to place the rest of the attachments while the patient is, or we're waiting for the patient's topical anesthetic to take hold. So we've got plenty of time because we want to wait for at least 10 minutes for the BTT topical to take effect. And then at the same time, I'm also finishing the IPR. And then at that time, we conduct the manual osteoperforations. We instruct the patient once again to identify proper aligner tracking to make sure they are very clear on that. I also advise the patients that if they get in a situation where they're not sure, to take a photograph and to send it to me so I can make the decision of whether the aligners are tracking. And once again, I always focus on telling the patients to look at those maxillary lateral incisors because those are the teeth that are most likely to unravel and to untrack. And if they're tracking properly, chances are the rest of the teeth are tracking. And then we deliver 10 aligners and we see them in 30 days. And I tell the patients, even if they haven't used all the aligners, to bring them back, but especially after the first administration propel, and if you've got a cooperative patient, they're usually pretty good on a 3, 4, 5 day aligner protocol. And now I no longer use the hand instruments. I'm using the power driver because with this, the MOPs can be administered in a very short period of time compared to what it used to take me. And so now I really rely on this. In fact, I own 2 of them now because now that I'm doing more with my Invisalign patients because of MOPs, my average protocol is really going 6 to 6 because I'm trying to get a broadened arch form for all of my cases because I feel that they're more nathologically sound. And this power driver is great. It's got a rotating contralateral head so I can get easy access. It's been particularly important if I'm trying to intrude posterior teeth for closing interior open bites because I can get this thing between the first and second molars, and that's what I want to do. I want to get in there and really mop up those that bone all the way to the posteriors so that I can help expedite the intrusion of those teeth. And at least my clinical experience seems to suggest that this is working out very well with these patients. And the perforations are easy to create. I think in my own personal, it obviously accelerates clear plastic aligners, and it seems to be expediting my braces cases for the ones that I use MOPs. And the setup is very easy with the BTT. We have a timer. All it takes is we fold the gauze, we put a line of it on, we administer it, and so the open-ended area of the gauze is towards the gingival so it doesn't leak out, it doesn't create a mess. We use the cotton tip just to tuck this thing in to make sure that the BTT stays in this so that it's almost like a sling with the open end towards the gingiva. And it's very easy. It's not messy at all, and then it works very well. And we just use the timer to ensure that we've got this BTT on for at least 3.5 minutes. And you can see you can walk away from it without anything falling apart. I prefer this method over the individual squares that I've seen other practitioners do, because I think this is a lot easier to implement. After we've allowed the BTT to seep in, then I go ahead and test it with an amalgam plugger. And I tell the patients you should feel pressure, but you shouldn't feel pain. If they feel pain, then I have the choice of doing a little bit more BTT for another minute, or at that point, if it's just one local area, then I'll get out the Septicane. I used to be very reluctant to use local anesthetic, and now it's not a problem for me at all, especially since I've already administered the BTT. I'm very comfortable with it now. And then I'm very comfortable with using this driver. It works so beautifully and works so easily, and everything's clean. And I don't have the discomfort that I sometimes got with the hand driver, because just by using the hand driver, the torque alone sometimes creates some trickle-down effect to the periodontal ligament of the adjacent teeth and cause some sensitivity. I'm not getting that with this power driver, simply because it's a clean perforation and it doesn't radiate adjacent to the rich nerve endings that are in the periodontal ligaments of the adjacent teeth. And you can see I don't have any problem. Obviously, it looks a little disconcerting initially, but even with these perforations, never bring this up to the patient. The patients don't bring it up to me. And like I said, with over 100 100 cases of MOPs, never had a patient have any problems with these, because wounds in the mouth heal very quickly. And you can see we go all the way to the back, especially if we were trying to change arch form or intrude teeth. And so I had the opportunity to put in writing my experiences with all three of these drivers. And obviously, in this particular article, I've actually promulgated the Excellerator PT, because there's no other way to do MOPs in my personal experience. And you can do more patients, you can do it with ease, and there's no problem with your wrist in doing this. And to me, it's the only way to go. So I found that by age 15, on average, male teens are often resistant to any orthodontic treatment. So it's a real challenge. That's why I'm such a promulgator of phase 1 treatment, because at that point, at age 9 or 10, the patients are very cooperative. Once they get to be teens, the last thing in the world they want to think about is orthodontics. They want the straight smile, but they don't want to be in any type of orthodontic treatment for any extended period of time. And so I've found that accelerated treatment modalities offer these teens an opportunity to significantly truncate their treatment time. So I don't have any problem offering MOPs to male teens. And this is a classic example. A 19-year-old, he's on his way to his first year of college, and he came in and he said, I really have to do something about this. This crossbite's bothering me, but I can't be in braces. He said, I need Invisalign, but I don't want to be in braces, in Invisalign treatment for more than a year. And so I told him, I said, with all these things that I have to do, the only way to really address all these problems is with MOPs. And he said, okay, then let's do it. And so once again, 32 aligners. In the old protocol, that would have been 18 months of treatment. In my mind, I've got a lot of work to do. I'm more concerned about the axial inclination and the extrusion of this canine than I am about any of the other treatments there. And you can see with the I have to distal drive these molars to create space to bring these teeth out and to get a decent arch form. And once again, just focusing on this lower right canine, I've got to use a vertical attachment to get the axial inclination and at the same time expand, and then change to horizontal beveled to get to simultaneous extrusion and retraction in order to meet all my treatment objectives. So within 32 aligners, 8 months of treatment on a 7-day exchange protocol, simply because he wasn't wearing his aligners 20 hours a day. But we're still able to get a reasonable result in a reasonable amount of time and meet everyone's objectives. And I'm not unhappy with that lower right canine. And then I got this, obviously been through a first phase of treatment, but he's a hockey player, and the last thing in the world he wants is braces. He wants Invisalign. But this is problematic for me because I know that these posterior spaces and the occlusion has to be finalized by slipping buccal segments forward. Any attempt to close these spaces by retraction of the incisors is more likely to involve in heavy anterior contacts and result in a posterior open bite, which is very common across the United States from my own personal experience. So the only way to deal with this and slip these buccal segments forward in my mind is with Propel. And so he was on, I said, oh, you're a hockey player. You can, if you're used to getting slammed against the board, then MOPs is going to be easy for you. And so he said, then let's do it. And you can see I've got quite a bit of significant space to close. And all this space has to be closed by slipping these buccal segments forward. And once again, 66 aligners. Just do the math. That would have been a 3-year program for me in the olden days. I've got a lot of work to do with cleaning this up, getting some type of reasonable smile arc. But the real problem for me and the real number of liners is due to the right buccal segments. In order to slip these buccal segments forward, I've got to use this attachment and the 45-degree gable bends, and then maintain these gable bends throughout the space closure and uprighting the crowns at the very end of the space closure treatment. So this is where all these aligners are coming from, but with Propel, it's not a concern for me. And on the 3, 5, 7-day exchange, aligner exchange protocol, with 66 aligners, he was able to finish his treatment in 12 months, get a nice squared off, broadened arch form, which I want, and close spaces, get a decent smile arc, and a reasonable overjet and overbite finish. And I'm not unhappy with the root parallelization. And so naturally, once again, I'm pushing the envelope, and here's a very compliant patient who wants to be finished, and he was told that the only way to correct this crossbite at his age is to undergo a surgical procedure. And once again, now that I've had a significant experience with MOPs, I felt that with MOPs in conjunction with Class 3 elastics to correct that mandibular shift, and with Invisalign, we had a reasonable shot at getting him done in a reasonable period of time. So 6 months into treatment with MOPs, we've already gotten him out of the crossbite. And at the 9-month mark, now he's ready to be scanned for refinement. So at this point, before I refine him or scan him, I'm putting these ceramic buttons any place I think I might need elastic, whether I'm going to need that elastic or not. I'm still working on Class 3 elastics with his midline shift, and now it's time to do some vertical elastics. So I've literally got him dressed up all over the place with these elastics. But at 10 months, he seems to be in pretty good shape. He's already had his second MOPS procedure, and he's flipping out the aligners every 3 days. So after 79 aligners, we're only 14 months and 3 weeks into treatment, and I'm just wrapping him up with vertical elastics, and I think then we're done. I couldn't imagine doing this case without MOPS. It's changed my practice. So my own personal experience is I think there's enough science-based evidence together with clinical trials and experience to acknowledge that accelerated orthodontic devices definitely have a place in orthodontic treatment. And manual osteo-perforation devices have proven to dramatically reduce treatment time, especially within my own practice, and specifically when used in line of treatment. And this treatment combination will likely prove to be an orthodontic disruptor comparable to that was created with the first introduction of aligner therapy back in 1999. And after using all 3 MOPS devices, I much prefer the MOPS power driver, and having witnessed the reaction of patients who experienced both, because when I got the power driver, I started using them on the refinement MOPS, and I found that the patients were much more comfortable with them, and I found that the power driver to be more efficient, more productive, and far more patient-friendly. And having appreciated the benefits of accelerated orthodontic devices in my own practice, I'd at the very least encourage clinicians to evaluate these devices for their own orthodontic treatment procedures. I don't take it for granted. I appreciate your attention and your attendance, and bless your collective hearts, and I'm open for any questions. And I've got a question. I missed the first part of the presentation. How do you do the 357 aligner exchange? Well, basically it's this. First of all, after you do the MOPs, there's a good possibility that patients aren't focused on listening to you. So I would suggest that at your first appointment, that's when you teach them what good tracking is. And then I tell them that after we do the MOPs, they're going to be in charge of their own treatment and moderating it. So I tell them that they're going to be on a 3, 4, 5, 6, or 7 day aligner exchange, and they're going to determine when to exchange the aligners. Now, my experience is if patients are wearing the aligners 20 hours a day, then you can follow the Shipley protocol of exchanging them every 3 aligners. It works beautifully. But in my own practice, patients aren't that compliant with their aligners, even after going through MOPs. So that's why I've changed to a 3, 5, 7 day or 3, 4, 5, 6, 7 day aligner exchange protocol. After we do the MOPs, I reiterate what the importance of making sure that they don't exchange the aligner until they have perfect tracking. And after 3 days, I tell them to look at those maxillary lateral incisors. If they're tracking perfectly, then to exchange them. Oftentimes, the patients will tell me everything looks good except the one maxillary lateral incisor. I tell them to vigorously use their chewies and examine it the next day. And if it looks good, then flip it out after the 4th day. If it needs another day, then use the chewies. And then the next day, if it looks like it's tracking, then you flip it out after 5 days. It matters not. The important thing is this, and this has been a benefit in my own practice. Now I'm dumping the responsibility back in their laps where it belongs. They're responsible. So if they untrack, they know that they're the culprit, not me. And the reality is these patients aren't untracking. They're able to assume responsibility. And although I've told them if they have any doubts to take a photograph and send it to me, that just doesn't happen. They seem to take responsibility because once they've done MOPs, they get real serious about their Invisalign treatment. So this has been a real boon to me. It's been real successful in the practice, and I've been very happy with the results. Thank you for the question. Thank you so much. Are there any drawbacks to having them wear aligners for 7 days? No. The only drawback in my mind is we're wasting time. I've got to tell you that I'm done with the 7-day aligners. After having experienced MOPs and aligners, this 3, 4, 5, 6, 7 day protocol is fabulous, and I'm sticking with it. So I've got a question, Dr. Cole-Adams. Is there any data for what is achievable with MOPs in terms of rate of orthodontic movement? Well, with regard to scientific data, to my knowledge, it's difficult simply because we're talking about working on animals. And animals, although we do extrapolate data, and it does suggest that it does accelerate treatment when you're using springs and moving teeth through bone. The most important thing in my mind is clinical experience. And for my own practice to witness these types of results with these aligners, which I've just showed you, it's remarkable. And so in my mind, clinical experience justifies what Shipley originally said about flipping them out every 3 days. And I've found that this 3, 4, 5, 7 day schedule is working very well for me. And so I've got a question from Dr. Anderson. What are you charging for MOPs? I'm charging $200 per quadrant. If I'm only doing maxillary incisors, that to me is 1 quadrant, so that's $200. I very seldom do that. If I'm doing just interior only, it's the uppers and the lowers, and that's a $400 procedure. If I'm trying to really get that nathological arch form, which is really what I'm trying to accomplish in most of my patients, and since most of my Invisalign patients present with bimaxillary constriction or collapsed arches, I'm really doing 4 quadrants of MOPs, and that comes out to $800. Thank you for the question, Dr. Anderson. It's great to see you. Another question from Dr. Amari. How often do you do the MOPs? Well, let me tell you this. I'll tell you that I've never had a patient say they've enjoyed the procedure. And in fact, a lot of patients will say, I don't know if I want to do that again. But the great thing about MOPs is you only have to do it once. If you're finishing your cases in 3 to 6 months, you only have to do it once, because I think that MOPs last for a period of 4, 5, or 6 months. And it doesn't matter to me if by month 6, we're now flipping out the aligners every 5 or 6 days instead of 3, 4, or 5 days. The important point is I'm accelerating the rate of aligner exchange, and that's very important to me. Now, for several of the patients that I have in my practice that I have, because the more MOPs and aligners you do, the more complicated procedures you do, I am having to do MOPs more than once. But these patients are motivated to get the job done. And once you've done MOPs and the patients have seen, especially on very complicated cases, how dramatic the results are in such a short period of time, it's no problem suggesting MOPs again. They said, let's do it. So it hasn't been a problem for me. And thank you once again for your kind responses, and I appreciate it. So if there's no further questions, then I will bid you adieu. Thank you once again. I appreciate your attention and for joining me in this webinar. Enjoy your evening.